Okay, so this is the continuation of the extradural hematoma, which is the third video. So what is the pathophysiology of ICP? What's your idea about Monroe-Killian doctrine hypothesis? So the skull is a fixed box containing three components: brain 80%, blood 10%, CSF 10%, ICP or volume, intracranial pressure, volume relationship is combined by these three components. Increase in volume in one component may result in compensated decrease in the volume of the another component in order to prevent rise in intracranial pressure. So this is Monroe-Killian doctrine. However, once the ICP has reached around 25 mm of Hg, a small increase in brain volume can lead to marked elevation in ICP. So, brain volume or edema or hemorrhage, anything which can increase the brain parenchyma, it can go up to 25 mm of Hg, like normally 7 to 15 mm of Hg of intracranial pressure. So it can go up to 25 mm of Hg, but after 25 mm of Hg, there will be abrupt increase in the ICP. For example, if we check the relationship like this, so up to 25% it can go normally like this, but about 25%, sorry, 25 millimeter of Hg, they are like, yes, about 25 millimeter of Hg. If there is a bit increase in the parenchymal volume of the brain, then there will be a rapid increase in pressure, ICP. So this is Monroe-Killian doctrine hypothesis. It has said that the brain and skull cavity, this is like a box containing this brain, arterial blood, and the CSF as three components. So if you increase the brain, then there will be you have to remove the CSF and so on, like for blood and the volume of the brain. So we have lucid interval, a temporary improvement in a patient condition after traumatic brain injury, after which the condition deteriorates with rapid decline of consciousness. During this period, the blood accumulates in the extradural space, leading to an increase in ICP, leading to cerebral edema. So let's suppose we have this brain and there is trauma to the skull. So at first, when there is trauma, so there is traumatic loss of consciousness, but after this loss of consciousness, there is a brief time of normal, like interval, and during this time the blood accumulates and then compress the parenchyma again, and the patient will get down again. So this is a typical feature of extradural hematoma, a temporary improvement in the patient condition after traumatic brain injury, after which the condition deteriorates very rapidly. During this period, blood accumulates in the brain. How will you measure CCP, cerebral perfusion pressure? How is it related to mean arterial pressure? So normal CCP is 75 to 105 millimeter of Hg, mean arterial pressure is 90 to 110, and intracranial pressure is 5 to 15 or 7 to 15. So mean arterial pressure minus the intracranial pressure, this will be equal to cerebral perfusion pressure, CCP. And mean arterial pressure is diastolic pressure plus 1/3 of the systolic pressure minus diastolic pressure. So this will give you the mean arterial pressure. Okay, so they can ask like how to calculate the cerebral perfusion pressure. Mean arterial pressure autoregulation range is between 50 to 150 millimeter of Hg. To maintain a constant cerebral blood flow, increase so mean arterial pressure, mean arterial pressure. So mean arterial pressure is the autoregulation. So it is regulated in the range of 50 to 150. Okay, so to maintain a constant cerebral blood flow. Okay, so in cases of traumatic brain injury, this will be disrupt. There will be disruption of mean arterial pressure autoregulation, so cerebral ischemia will occur. So if there is, this means that if there is a raised pressure, so mean arterial pressure will go down up to 50. Up to 50, this can go, this is a limit. And for raised, if there is a low intracranial pressure or like hypotension, so it will go up like up to 50. So this is autoregulation. It occurs by itself in the brain. Why? Because it's a vital organ. So what are the clinical pictures of increased ICP? So the patient will feel headache, nausea, vomiting, papilledema, fall in GCS, ischemia, loss of autoregulation, mean arterial pressure, pressure symptoms like hematoma, uh, dilated pupil, loss of accommodation, downward and outward gaze, which is oculomotor third nerve palsy, downward and outward, on loss of accommodation reflex as well, and defect in lateral gaze, horizontal diplopia, abductor nerve palsy. Sectional palsy will also occur, and Cushing triad, not to be confused with Cushing reflex. Increased systolic blood pressure, widened pulse pressure, and bradycardia and irregular respiratory system pattern. Okay, so these are the diagrammatic representation of the increased intracranial pressure. So indication for intubation when GCS is less than or equal to 8, risk of raised intracranial pressure due to agitation, sedation required, inability to control or protect the airway or loss of protective laryngeal reflexes, a fall of 2 or more points in the motor component of the GCS. In the motor component, a fall of 2 or more in the motor component. In order to optimize oxygenation and ventilation, seizures, bleeding into the mouth, airway, bilateral fracture, mental, severe facial injuries. If planned to transfer to another ward, do prophylactic intubation. How will you maintain CCP, cerebral perfusion pressure, IV fluid, mannitol to decrease intracranial pressure, cooling of brain by phenytoin or barbiturates, and hyperventilation. What are the different management options for a patient with raised intracranial pressure? So first, I will manage the patient according to a TLS protocol in ABC. So if there is bleeding, I will first take control of it. This is for C. And then like the ABCD manner, improving venous drainage from the brain, elevation of the head of bed to 30 degree, good neck alignment, head in the neutral position, ensuring ties holding the endotracheal tube in place do not compress the neck bands. Alternatively, tape the tube using trouser legs. Where possible, immobilize the patient's cervical spine with sandbags and tape rather than restrictive neck collars. It can also cause pressure sores as well. Reducing cerebral edema, use mannitol, an osmotic diuretic, 0.5 to 1 gram per kg. 5 to 10 ml, this is in ml per kg of 10% or 2.5 to 5 ml per kg of 20% mannitol. Some units use small aliquots of hypertonic saline as an alternative, but mannitol is superior. Use furosemide loop diuretic 0.5 to 1 mg per kg. Maintain serum sodium in the range of 140 to 145 mmol per liter. So this is reducing cerebral edema. Reduction of the cerebral metabolic rate for oxygen, close temperature regulation, avoid hyperthermia but do not actively induce hypothermia. Use of sedation and anesthetic drugs, ensure that the patient is appropriately sedated and has received adequate analgesia. If the patient has a witnessed seizure, loading with an anticonvulsant, usually phenytoin 18 mg per kg should be considered. In case of intractable raised intracranial pressure, thiopentone infusion can be used to reduce the cerebral metabolic rate to a vessel. This is therapeutic coma. So when you induce the therapeutic coma, it will reduce the metabolic rate of the brain cells, and this is identified on EEG. Okay, monitoring or burst suppression. So this how you reduce the intracranial pressure. Reducing intracranial blood volume. Hyperventilation, when you give oxygen, hyperventilate the patient. This will, because in ischemia, if there is ischemia or like decreased oxygen, so mm, the brain cerebral vessels will dilate, which can also lead to raised intracranial pressure. But providing hyperventilation, this will reduce the partial pressure of CO2 as a temporary measure. So this will constrict the cerebral vessels, and it can decrease the raised intracranial pressure. So hyperventilation can be used to reduce the partial pressure of CO2 as a temporary measure, but cerebral ischemia may result if this is prolonged. So because it will constrict the cerebral vessels. If only coning occurs, otherwise avoided as a secondary brain damage due to ischemia may occur. Reducing CSF volume in a neurosurgical center, use of external ventricular drain (EVD) allows drainage of CSF to relieve raised endocrine pressure. This is very effective, but this should be done in a specialized neurosurgical setup. Surgical decompression by removing hematoma by burr hole. If diffuse injury, then decompressive craniectomy. So this was about the epidural hematoma.